Hi, and welcome to the first international online symposium on expert meeting for the best practice in fertility preservation. This symposium was initially planned to attract colleagues from Turkey and its surrounding countries. Besides its challenging scientific program, we had chosen a very attractive place, Istanbul, the city that combines not only the continents, but cultures that have shaped our civilization today. Now the technology helped us to overcome the negative effects of pandemic and to turn the organization into a virtual meeting. In its current form, the same challenging and attractive scientific content is now embedded with a virtual conference center where you can move around as if you are in a real meeting and join all attractions and events free from time and location dependent restrictions. We have no doubt that attendees of our symposium will have unique experiences within the virtual symposium environment. Now that you have been through the registration process, let me briefly inform you and guide you how to navigate the virtual symposium environment. Although I can feel the crowd in the meeting, I don't need to worry about the queue in the registration or information desk. No need for social distancing and carrying a mask. In all meetings, attendees frequently look up the scientific program in order not to miss the presentation of his or her interest. So in this platform, you can simply click on the kiosk screen to view the main program anytime you like. Likewise, you have a question, all you need to do is to visit us from the info desk. Not to mention, you are welcome to send us email at any time you like. This is the invited faculty hall. As you can see from the scientific program, we host numerous international well-known speakers in the meeting. In a real meeting, one can hardly find a way to ask questions, but in this platform, it is something that you can easily do without a hassle. Even during the presentations, you can meet the invited faculties in this hall for your questions. Be sure that 19 fertility preservation experts from 8 different countries will be here to share their knowledge and experience with you for 3 days. Here, you can see the door for the conference hall, where main program lectures will be given. We will start live broadcasting on September 11th at 17:30 from conference hall. We have organized a very challenging scientific program, so please don't miss these featured presentations. But for some reason, if you do, all lectures will be recorded and be available for registered participants after the event. Fertility preservation requires multidisciplinary approach that can combine numerous other medical specialties, many experts from different societies. In the affiliated science societies hall, our attendees can find the booths and interact with different affiliated societies, get information, learn and follow their activities. You can also apply for a membership by just several clicks. To access the exhibition area, you will be clicking this door. Exhibition hall will be open 1 day before the Congress starts, so you would have enough time to visit the exhibition area, take a look at the booths and engage with the company representative to get more information regarding their products and services portfolio. We will be doing best for you to enjoy the meeting by keeping you comfortable from wherever you will be joining the meeting. We all look forward to welcome you on Friday, the 11th of September at 17:30 a.m. Central European Time. Thank you and looking forward to welcoming you in our symposium. In the meantime, I wish you good health during this challenging time. Thank you.
Dear guests, welcome to the first online international symposium on fertility preservation. As you all know, fertility preservation is a rapidly growing field of reproductive medicine. Turkish Society of Fertility Preservation Symposium Series aims to gather key clinicians and scientists who are expert in their fields in order to discuss the most relevant topics ranging from cryobiology, ovarian biology to ovarian stimulation protocols and artificial gonads. As the president of the Turkish Society of Fertility Preservation, I would like to welcome you one more time on behalf of myself and all board members. Thank you.
When you're constantly evolving and looking to make the world a better place, you never stop. That's why we'll never stop, building on our history to continue to transform the world of healthcare. We'll never stop saving doctors critical time by turning complex CT and MRI data into 3D images using our healthcare IT systems, which allows surgeons to create simulations before operations ever take place. Working to develop miniature endoscopes to ease patient anxiety during uncomfortable procedures, and point-of-care ultrasound machines that can travel to previously unreachable places. We'll never stop evolving visual imaging technologies engineered to help doctors identify difficult-to-detect diseases earlier. Pioneering the world of pharmaceuticals with advanced drug delivery technologies that use nanoparticles designed to target diseases. Advancing the field of regenerative medicine by applying cutting-edge development and production technologies to provide high-quality iPS cells, which contribute to cell therapy. Pushing the boundaries of biomedicine to help fight diseases like cancer and expand the possibilities of healthcare. And we're entering the fight against aging by using our antioxidant knowledge that prevents film from aging to help advance skin care. Of course, we're just getting started. We'll never stop improving the future by transforming healthcare through advancing the fields of medical prevention, diagnosis, and treatment. And we'll never stop creating value from medical innovation to make the world a stronger, healthier, more livable place. Never stop advancing healthcare. Fujifilm, value from innovation.
Experts from all over the world will be with us to discuss the basics, current state, and innovations of fertility preservation. Please don't miss this outstanding virtual symposium and mark your calendar from 11 to 13 of September. I will be there. Will you?
Mein Name ist Horst Wolf.
My name is Horst Wolf.
Ich bin im Hause Zeiss.
At SYMPOSIUM, I'm responsible for inverted research microscopes in life sciences.
Als Zellbiologe habe ich mir immer
As a cell biologist, I've always wanted a flexible imaging system that would let me perform all different kinds of experiments, but still be easy to operate.
ein stabiles System, das vielen
A
unterschiedlichen
stable system that would create optimal conditions for a whole range of samples and deliver reproducible results every time.
mit
Axio Observer is everything I'd hope for. It lets you combine a wealth of technologies with options to fine-tune it precisely to your experiments.
Sie nutzen die
It uses novel LED illumination for gentle and reproducible imaging.
Wählen Sie aus einem breiten
And you can
Portfolio
choose the perfect
genau
objectives
passende
and contrasting methods for your applications from the wide-ranging Zeiss portfolio. Expand your Axio Observer with AutoCore, and you will always be imaging your samples with the highest resolution and best contrast. Definite Focus 2 focuses your sample automatically and keeps it sharp, even during long-term time-lapse experiments.
Axio Observer ist Ihre
Axio Observer is your stable inverted platform for the challenge of imaging living or fixed specimens.
Weitere Informationen
For further information, visit our website.
As a radiation oncologist, I invite all cancer professionals, including radiation, medical and surgical oncologists, to participate in this symposium, to hear and discuss the timing and current state of art in fertility preservation. Let's focus all together for the best possible functional survival. Looking forward to see you all together in this symposium.
Impril, mitochondrial micronutrients.
Hello, this is Dr. Karlıkaya. Dear guests, due to the time limitation and case-specific problems, specialized stimulation protocols are needed in fertility preservation patients. You can find the answer of your questions by joining to our symposium. You will have a chance to listen to the expert on this field.
Dear colleagues, we are hosting the most experienced physicians to talk about the current practices and future innovations in fertility preservation. Isn't it great? Move to a comfortable chair, grab your coffee, and enjoy this wonderful session.
Hi, and welcome to the first International Online Symposium on Expert Meeting for the Best Practice in Fertility Preservation. This symposium was initially planned to attract colleagues from Turkey and its surrounding countries. Besides its challenging scientific program, we had chosen a very attractive place, Istanbul, the city that combines not only the continents, but cultures that have shaped our civilization today. Now the technology helped us to overcome the negative effects of pandemic and to turn the organization into a virtual meeting. In its current form, the same challenging and attractive scientific content is now embedded with a virtual conference center where you can move around as if you are in a real meeting and join all attractions and events free from time and location-dependent restrictions. We have no doubt that attendees of our symposium will have unique experiences within the virtual symposium environment. Now that you have been through the registration process, let me briefly inform you and guide you how to navigate the virtual symposium environment. Although I can feel the crowd in the meeting, I don't need to worry about the queue in the registration or information desk. No need for social distancing and carrying a mask. In all meetings, attendees frequently look up the scientific program in order not to miss the presentation of his or her interest. So in this platform, you can simply click on the kiosk screen to view the main program anytime you like. Likewise, you have a question, all you need to do is to visit us from the info desk. Not to mention, you are welcome to send us email at any time you like. This is the invited faculty hall. As you can see from the scientific program, we host numerous internationally well-known speakers in the meeting. In a real meeting, one can hardly find a way to ask questions, but in this platform, it is something that you can easily do without a hassle. Even during the presentations, you can meet the invited faculties in this hall for your questions. Be sure that 19 fertility preservation experts from 8 different countries will be here to share their knowledge and experience with you for 3 days. Here, you can see the door for the conference hall, where main program lectures will be given. We will start live broadcasting on September 11th at 17:30 from conference hall. We have organized a very challenging scientific program, so please don't miss these featured presentations. But for some reason, if you do, all lectures will be recorded and be available for registered participants after the event. Fertility preservation requires multidisciplinary approach that can combine numerous other medical specialties, many experts from different societies. In the affiliated science societies hall, our attendees can find the booths and interact with different affiliated societies, get information, learn and follow their activities. You can also apply for a membership by just several clicks. To access the exhibition area, you will be clicking this door. Exhibition hall will be open 1 day before the Congress starts, so you would have enough time to visit the exhibition area, take a look at the booths and engage with the company representative to get more information regarding their products and services portfolio. We will be doing best for you to enjoy the meeting by keeping you comfortable from wherever you will be joining the meeting. We all look forward to welcome you on Friday, the 11th of September at 17:30 a.m. Central European Time. Thank you and looking forward to welcoming you in our symposium. In the meantime, I wish you good health during this challenging time. Thank you. Hi, and welcome to the third and also the last day of our International Online Fertility Preservation Symposium, which is organized by Turkish Society of Fertility Preservation. Now we approach to the fifth session of the meeting, and since the beginning of the first session, we have been receiving lots of positive and nice messages from our attendees. Such feedback truly motivates and encourages us to continue such activities in the near future. Please stay tuned with our society's social media accounts to get the latest news and events. With Dr. Güvenç Karlıkaya, I will be chairing the fifth session, which includes three distinguished speakers, Dr. Glenn Shatman from USA, Dr. Ana Cobo from Spain, and Dr. Kutluk Oktay from USA as well. Now I'm passing the microphone to my co-chair, Dr. Güvenç Karlıkaya, in order for him to introduce the first speaker of the session.
Okay, good evenings. And as all we know, oocyte and embryo freezing has become extremely important to maintain fertility capacity for the women who are struggling with cancer. Unfortunately, the limited time period between cancer diagnosis and the initiation of fertility impairing treatments complicates the use of traditional ovulation induction protocols. Therefore, there's a need for newer protocols which allows us to produce sufficient numbers of oocytes in a shorter time. Dr. Glenn Shatman, who is a well-known expert on ovarian stimulation protocols, will talk about different stimulation protocols in these patients. Dr. Shatman is an associated professor at the Ronald Perelman and Claudio Cohen Center for Reproductive Medicine of Cornell Medical College. He completed his fellowship and became faculty member at the same institute in 1993. Besides his teaching and mentoring jobs at the same faculty, he is currently focused on fertility preservation for cancer patients. He was a founding member of the Alliance for Fertility Preservation and now serves as its chairman. He is also involved in many research on ovarian tissue cryopreservation. Dear Glenn, my friend, it's a great pleasure for me to introduce you for your talk.
Thank you very much. I hope you can hear me well. I am getting a message here saying network problems, but hopefully that works out okay. I wish I was there in Istanbul in Turkey with you. Unfortunately, due to the present situation, I'm not able to be there. But I'm very excited to give this talk on ovarian stimulation protocols for egg freezing and also embryo freezing in cancer patients. It's my mouse. There we go. First, I have no financial relationships to disclose. And I'd like to discuss on this presentation the current protocols for ovarian stimulation in patients undergoing fertility preservation. I'd like to discuss methods to maximize the outcomes with the choice of medications and immediate treatment and not delaying treatment. Discuss the choice of the ovulatory trigger so we can actually perform back-to-back stimulation protocols and maximizing our retrieval success. So there's a lot of options we have when preserving fertility. Clearly, I'm going to talk about the top left part of the screen here, the ovarian stimulation, for egg retrieval for either egg or embryo freezing. We're not going to talk about ovarian tissue freezing or options that I'm sure has been discussed or will be discussed by others. So in 2019, you can see that the ASRM actually took out the experimental nature or the experimental label on ovarian tissue freezing. So that adds another option for these fertility preservation patients. So if you look at what we can freeze, and now people really focus on eggs or blastocysts, but 2P and embryos also freeze very well. In fact, if you look at the blastulation rate of frozen eggs, it's actually a little bit lower. So if we're going to do genetic testing for mutation or something like that, we prefer to freeze blastocysts if the patient has a long-term partner. If not, we freeze eggs, or you can freeze 2P and embryos. But you can also, don't forget about day 3 embryos and freezing those, because that also has for many years resulted in very good success rates if you're not doing genetic testing of the embryos. So when we talk about eggs and embryo freezing, we have to have a decent number of eggs and embryos to freeze. If you're young, and actually most of the ovarian tissue is in patients under the age of 35, if you compare the ovarian tissue freezing success rates to egg freezing success rates, it's around 8 to 10% per egg. And patients under 35 tend to get a lot of eggs. We want to maximize the number of eggs we retrieve from any patient group, whether they're under 35 or whether they're 40 or 41, 42, even though it's a lower success rate per egg, the more eggs they get, the better their chances are of having a child in the future. And in the younger patient population, even more than one child. So let's look at nature and how nature provides us with ovarian stimulation, or normally stimulates a single follicle to develop. And if we look at this, early on in the cycle, you have a number of potential follicles available. In nature, there's an FSH rise to get the follicles to grow, but don't forget about some endogenous LH activity that is also required. And when we treat our patients with either an analog or an antagonist of GnRH, they tend to suppress LH levels and sometimes below the threshold for normal follicular growth. So don't forget about the LH component. We'll talk about that in just a second. But with the ovulatory stimulus, you see a rise in LH, and we've always used HCG in patients that are down-regulated. However, there is naturally an endogenous FSH rise that may have a positive impact on the health and the development of that oocyte. So let's take a look at that in a second. When we talk about ovarian stimulation, as the moderator mentioned, we have a group of follicles that are always there, and traditionally, because of patients trying to get pregnant, we've started our stimulation protocols on day 2 of the cycle to prepare the endometrium. But there are always follicles available, always developing. I don't believe in 1 or 2 or 3 waves of follicles. These follicles are always developing, and you'll always have a cohort of follicles you can start stimulating. So we start them at any point in the cycle, and I'll show you that in just a second. When they come in to see us, there's no delay in treatment. We pretty much start them right away or within 2 or 3 days of seeing us, no matter where they are in the menstrual cycle. We use an antagonist even in the luteal phase, and I'll talk about that in a second, because we don't want to lose their oocytes. We have 1 shot or sometimes 2 shots. We want to get as many eggs as we can. We use a GnRH agonist for trigger, and I'll explain why that is in a second, and retrieve the eggs and freeze them or make embryos. So let's take a look at, we sort of forget a lot of the original studies that were done, and these studies were done back in the early 1990s. If you take a hypo patient and you treat them with recombinant FSH, it takes longer to stimulate those patients here. They need more drugs and they get fewer eggs. Now, it's not just that they get fewer eggs, but you also have a lower fertilization rate per egg because there's something abnormal about the egg. And if you treat them with LH activity, they have normal development, normal number of eggs, normal estradiol production, and normal fertilization rates. In fact, this is a little bit high, but normal fertilization rates. So there's something about a lack of LH or deficient LH that causes bad egg quality. You can get eggs and you can freeze eggs, but don't expect that those eggs are going to contribute much to a positive outcome. And this is another study done also early 1990s, a number of patients, hypo treated with either HMG in the first column or recombinant FSH in the second column, or purified FSH in the second column. And you can see those treated with LH activity have used less drug and get more follicles than those that were not and given pure FSH. So if you look at our antagonist protocols that we currently use now, and pretty much in our institution, over 90% of our cycles are antagonist protocols, we essentially are making the patient somewhat hypothalamic by using the GnRH antagonist. So you can see here, the reason of the 0.25 dose was chosen is because that gave us the best outcome. But clearly, if you go to a higher dose, you have essentially a lower estradiol level on the day of HCG because you're essentially blocking LH activity significantly. You get fewer eggs retrieved, and you also have a significantly lower pregnancy rate per embryo transferred. So in these patients, there are some people that with a normal dose of 0.2 that we currently use, you'll see a drop in estradiol levels. You'll see an inappropriate low estradiol level per mature follicle retrieved, and you're essentially making those patients hypothalamic. So one of the reasons that our protocols almost always include some LH activity is exactly this reason here. So if you look at those patients that are poor responders, and they're given, and this is a relatively decent dose of FSH on a downregulated protocol, and we give them either FSH alone extra FSH, or we give them 150 units of recombinant LH, you can quite clearly see that with extra LH in poor responders, you get more eggs. You also get a higher egg quality in terms of implantation rates, as well as ongoing pregnancy rate, improved egg quality than just in the poor responders. So we can improve response, not just by number of eggs, but also by the quality of the eggs by adding some LH activity. Another study with a similar focus, essentially in poor responders, they compared to the normal responders. In the poor responder, just adding back a little bit of LH activity, essentially normalized the poor responder to the control population, where if we just added more FSH, we didn't get the response. We had a lower implantation rate compared to the controls or those that were added back some LH activity, as well as a lower implantation and ongoing pregnancy rate in that population. So by using LH activity and some LH activity, we can make sure that we have the highest rate of ovulation, we increase our fertilization rate, and increase our pregnancy rate, because an inadequate level of LH in that population results in poor outcomes of the eggs retrieved. So if we look at our follicular starts, or when the patient comes in, they're going to be in 3 phases of their menstrual cycle. They're going to be early follicular, like here. They have a follicle less than 14 millimeters, and I've really stolen this from the IVM data, showing that if the follicle at lead is over 15 millimeters, they have a lower chance of pregnancy and they have a poor outcome with the other eggs retrieved, because those follicles have already started to undergo atresia, and we can rescue them, but they're still poor quality eggs. So if their follicle at lead is less than 14 millimeters, we stimulate them. You can see here with FSH or and HMG. You can also just start the HMG or LH activity when you use the GnRH antagonist, which is going to be earlier because they've already got a follicle of 14 millimeters sometimes, and stimulate them, retrieve them as you would normally depending on the protocol you're going to give them. And the trigger we commonly use is a GnRH agonist only trigger in those patients. And the reason is because usually after retrieval, literally 3 or 4 days later, their ovaries will be back down to relatively normal size, and we can stimulate them again with another protocol. Now they'll be in the luteal phase, essentially. We can stimulate them again with FSH and HMG to retrieve more eggs. And we can maximize the number of eggs. We can get 2 stimulations in about 4 weeks or 3.5 weeks, as opposed to 1 cycle every 4 weeks. Now, if we look at the GnRH agonist trigger, there are some people that are afraid to use an agonist trigger and will use a dual trigger on everybody, or you will use some HCG on everybody. And we looked at our population of patients, and there were 424 patients, and we actually found about a 5 or 5.2% risk of suboptimal response. Now, what does that mean? That means an LH level of less than 15. So they didn't respond at all. And that's not really a problem, because in that situation, we can give them HCG the next evening and just delay the retrieval by 24 hours. It's the ones that have a response where LH is over 15, but under 50, where unfortunately those patients, they have a very poor response, and we can predict those pretty easily. So if we look at those that have a suboptimal response to a GnRH agonist only trigger, it's really those that have a low baseline LH, less than 0.1, and a low LH level on the day of the trigger that give them a 25% risk of inadequate response. Those are oftentimes patients treated with long-term birth control pills or other types of pretreatment, or the true hypo patients that aren't going to respond to a GnRH agonist trigger, and those need HCG. So if we combine the baseline LH to the LH on the day of the trigger, those that have a low baseline and low LH on the day of the trigger have a 25% chance of non-response. If we eliminate those patients that have a low baseline LH that's undetectable, and also an LH level of at least 0.2 on the day of the trigger, our incidence of non-response goes down to 0.2%. 0.2%, not 5 or 25%. Now, why GnRH agonist versus HCG? Again, as I mentioned, GnRH agonists, we can lead to another stimulation within 4 days of the egg retrieval and stimulate them again. If you use HCG, the half-life is long enough that it causes problems for subsequent stimulation. But if you give those patients just pure GnRH agonist, you're again following nature and physiology, where you're getting an FSH as well as an LH surge. And this is one recent study done in about 333 patients, and it's retrospective. So unfortunately, it's not a study where you can actually prospectively randomize patients. So the ones that got a GnRH agonist essentially were maybe higher responders or different population of patients than those that got HCG. But since the subsequent cycle of the transfer, these were all genetically tested embryos, the subsequent cycle of transfer was done in a program cycle with oral estrogen and vaginal progesterone. You can separate out the stimulation response from the transfer or embryo quality. You can see here that the GnRH agonist group, they got more eggs, and maybe there was some bias towards giving those patients an agonist because they had more eggs and were higher risk of hyperstimulation than the HCG group. And if you look at the number of eggs they got more eggs in the agonist group, and that leads to more blastocysts and more euploid blastocysts. However, if you look at the percentage of embryos that made blastocysts, it's no different between the two groups, or euploid blastocysts, no different between the two groups. But if you look at the implantation rate, remember this is in a subsequent cycle of those blastocysts, it's a higher implantation rate per euploid blastocyst compared to those that got the HCG trigger. A live birth rate per embryo transferred, again, was higher in the agonist group versus the HCG group. So there's something different about the FSH surge that also maybe improves egg or embryo quality. So oftentimes patients that come to you are not in the early follicular phase of their cycle. They're in the late follicular phase, or maybe just going to ovulate soon. So if the follicle is over 15 millimeters, what we do is we trigger them, and you can retrieve that egg if you want to, based on how many what their ovarian reserve is. So you can go through retrieval, retrieve that one egg, and then stimulate them 3 days after the agonist is given. You stimulate them normally. They tell them to expect a period during the stimulation, but again, you can see we always use some LH activity, and usually in a hypo patient or OCP treated patient, we will give them 150 units of LH activity. In addition, anything else they need with FSH activity. We use an antagonist, even though they're in the luteal phase. I know there's some data out there showing that you don't need an antagonist in the luteal phase of these people's cycles. However, since they're cancer patients, we don't want to mess up their cycle. We still give them an antagonist as we normally would. We retrieve them based on the majority of follicles, recognize there'll be a corpus luteum there with a GnRH agonist trigger, retrieve, and you can again start stimulation 4 days later after the eggs or embryos have been frozen. And if they're already luteal, we do the same thing. We just start them right away. In the luteal phase, again, we still give them a GnRH antagonist and tell them to expect a period. An agonist trigger works even in the luteal phase of the menstrual cycle. They don't need a dual trigger. These patients respond beautifully to GnRH agonist alone, even if they're in the luteal phase of the cycle. We trigger, retrieve, and freeze. And again, you can start them right away again with another stimulation cycle right away. And if you look at the outcomes with any cycle, any part of the cycle, compared to a control group, and this is a paper we published back in 2017, in over about 860 control patients, you can see that when we match them for age and AMH and AFCs, that their response to stimulation is exactly the same, whether they start early follicular, late follicular with that trigger, and then start 3 days later, or luteal. Same number of eggs, same number of metaphase 2 oocytes here in the bottom line. The only difference is it takes another day or two of stimulation when you start stimulation in the luteal phase. And because of that, they need more gonadotropins because they go an extra 1 or 2 days with stimulation. These are not letrozole patients. These are pure stimulation, not for estrogen-sensitive diseases. And we've subsequently looked at our luteal starts versus our day 2 starts. And again, no difference really in number of eggs harvested, mature, or infertilized. So luteal starts don't compromise outcome at all compared to follicular starts. And this is a meta-analysis in 2016 showing just that. They take a little bit longer to stimulate, but really no difference in number of eggs retrieved or in fertilization rate. Now, Kutlik is going to talk about this in a little bit, but for our breast cancer patients, we do this essentially start stimulation, but if you have to add an aromatase inhibitor, you can do that at any time of the cycle. You don't have to start that at the beginning. So for our patients that we're doing a random start on, we start the aromatase inhibitor when they need it based on E2 levels, not based on where they are in the cycle. So early follicular luteal phase starts we just start the gonadotropin right away. There's no need to delay a cycle of stimulation, no need to delay from when you see them on day one when they come in for their initial consultation. And we give an antagonist based on the estrogen level of usually over 300 picograms per ml and follicle size of at least 13 millimeters. We start their antagonist. Again, luteal phase doesn't matter. We still do the same thing. In the late luteal phase, follicular phase, we trigger ovulation with a GnRH agonist and retrieve the egg, initiate gonadotropin stimulation about 3 days later. GnRH agonist triggers may improve egg quality. It allows for back-to-back stimulations 4 days after retrieval. And again, the aromatase inhibitors can be used in patients with estrogen-sensitive diseases that Dr. Aktay is going to tell us about. Thank you very much.
Thank you, Dr. Shatman, for this excellent and very comprehensive presentation. Introduction of new cryopreservation technologies, oocyte freezing, has recently emerged as an important part of IVF treatments. Although medical reasons like cancer treatments or other fertility impairing treatments are the main indications for oocyte freezing, social reasons have also become an important issue among the women who desire to delay childbearing. Now it's my pleasure to introduce our second speaker, Dr. Anna Kobo. Dr. Anna Kobo has been a well-known speaker for many years, and we'd like to thank her again to be with us today. And we know her from her landmark studies on human oocyte vitrification. But just to introduce her to the audience, let me say a few words about her. Dr. Anna Kobo graduated from the University of Valle in Colombia in 1988, and she obtained her master's degree in biological sciences in reproduction biology at the University of Chile at 1994. She moved to Spain in 1995 when she joined the Institute of Valencia in fertility and obtained a master's degree in human reproduction at the University of Valencia, Spain in 1998. She completed her PhD degree from the University of Valencia as well, and she has worked as an embryologist for more than 20 years and became interested in oocyte cryopreservation. She's currently a senior embryologist at the IVI in Valencia, where she is the director of cryobiology and unit in the IVF lab. She has published over 100 articles and book chapters, mostly on cryopreservation in IVF. Also, she's a professor in human reproduction at the University of Rey Juan Carlos and also the University of Valencia. And Dr. Anna Kobo, the stage is yours. Can you please open your microphone?
I'm so sorry about that. Can you hear me now? Hello? Can you hear me now?
Yeah.
Okay, so I'd like to thank the organizers for this very kind invitation, and thank you so much for the nice introduction. So the topic for today is the current status of oocyte freezing for social and also medical reasons, including cancer patients. So, okay. I'm sorry. This slide shows the main beneficiaries of current fertility preservation programs, which are a reality today in great part thanks to the efficient oocyte vitrification protocols and different methodologies for vitrification that we have today. So in first place, we have the elective freezers, which this alternative is also known as social freezing. And it is has to do mainly with the age-related fertility decline. And on the other hand, we have medical reasons, cancer disease in the first place, but there are also different diseases requiring immunochemotherapy, as some glomerulonephritis, arthritis rheumatoid, etc. But there are also other medical reasons in which the ovarian reserve can be also damaged or jeopardized, as in the cases of endometriosis, among others. So oocyte vitrification has demonstrated to be really helpful in all these cases. In fact, the use or the application of fertility preservation has greatly increased over the last decade. And this is data from our group in a study we published in 2018, in which we can see that the demand or the incidence for fertility preservation was 2% at the beginning. I'm talking about 2007, 2008, when we started our vitrification program. This 2% means that this is the percentage of oocyte vitrification cycles due to elective fertility preservation. It was 2% at that time, and a decade later, it increased greatly to 22%. And nowadays, it's around 35% of the vitrification cycles we do in our group are due to age-related fertility decline. So it has greatly increased. On the other hand, it was different over all this time. It was 2% for cancer patients. And we can discuss afterwards the reason for this lack of increase in the demand for fertility preservation in cancer patients. This study, which I just mentioned, shows actually the results we have achieved in these two populations, elective freezers and cancer patients. This is a large study, over 5,000 women doing elective fertility preservation and over 7,000 cycles. Among them, 12% have returned to use their oocytes to attempt pregnancy. In the case of cancer patients, we have over 1,000 women, and 80 have returned, so which is a much lower return rate, which is 7.4%. The great majority of these patients were diagnosed with breast cancer patients, followed by Hodgkin's lymphoma disease. What about age? In the elective freezers group, this is the distribution of age, and as you can see here, 80% of these women were older than 35 years old, and 73% of them were aged between 35 and 40 years, which is really advanced maternal age. This is the population of women who typically come to our facilities asking for fertility treatment, and they are freezing their eggs for fertility preservation at that age. So this is something we need to bear in mind when we analyze the outcome achieved by these women. And on the other hand, for cancer patients, the distribution of age is totally different, because as it's logical, they do freeze their oocytes when they are diagnosed with a cancer disease. So this slide shows the overall outcome for both populations, elective freezers and cancer patients. And the mean age, as I just mentioned, is almost 38 years old for elective freezers, and it is 35 for cancer patients. The storage time was longer for cancer patients, as this is totally expectable. They need to overcome the disease, and they have to get the permission from the oncologist, and etc. Survival rate was comparable, but a little high for elective freezers, and we will go back to this issue to perform a deeper analysis of survival and clinical outcome. As you can see here, implantation rate was 10 points lower in the group of cancer patients as compared to elective freezers. And this is really remarkable, because these patients are younger than the elective freezers. And the same thing happens for a clinical outcome. Although no statistical difference was found in the overall comparisons, the outcome was a little lower. So we have here the oocyte retrieval in both populations. We have here that the number of oocytes retrieved per cycle was lower in elective freezers, as we can see here, but when we compare the figures per patient, the comparison was no statistical differences were found. And this is because in the group of elective freezers, they were able to perform more than one stimulation cycle. So we had the opportunity to to retrieve some more eggs, and that's why when we calculate per patient, then the comparisons are not statistically, there are no statistical differences. Here we have the number of oocytes retrieved and vitrified per cycle in both groups, and according to the stimulation. I already mentioned that the great majority of patients in our cancer group were diagnosed with breast cancer, so we use the protocol of antagonist plus letrozole. And a little lower number of oocytes were retrieved in these cases when we and vitrified finally when we compared with the antagonist, and this is consistent with the previous publication by Domingo in 2012. And this is the number of oocytes retrieved and vitrified in elective freezers according to age, and this is totally expected. Well, because of the natural depletion of the ovarian reserve, we have fewer oocytes retrieved and vitrified as the age these patients get older. So this is totally expectable. So let's put all these things together and analyze how age, the indication, I mean the different populations using vitrified oocytes and the oocyte quality impact on survival, and finally on the cumulative live birth rate, which is obviously the final outcome. This is data from our donors program, and this study was published in 2015, showing that in this selected population of healthy women as donors, low survival or even survival failure exists. In this time was 1.4 of 0% survival rate in donors in our group. But which is really most interesting is that there is a kind of recurrence of this survival failure. So it is shown here. If we have a survival failure in the first cycle, same donor, the risk of having survival failure in the next cycle or in a second cycle multiplies by 2. And if they have survival failure in the first one and in the second one, this risk just increases by 5. So there is a kind of recurrence in this survival failure. Remember, this is our donor oocyte population. So we tried to perform to forecast the survival rate in this selected population. So we analyzed different factors as the number of oocytes in the cohort, which has nothing to do with survival rate, the body mass index, which is also not related to survival rate, and not any parameter of ovarian stimulation. Neither was the time of storage. As you can see here, after 5 years of storage of these oocytes, there is no incidence on survival rate, implantation, or pregnancy rates. And this is consistent with which we are observing in our fertility preservation population. So this is data for survival with among over 8 years of storage for elective freezers and for cancer patients. And as you can see here, survival rate is not altered by this storage time, which, by the way, is really, really good news. What about the oocyte quality? So this is a study published by Coelho from our group in 2019, showing how the different dysmorphisms that we can observe in these autologous oocyte cycles can impact on survival rate or on blastocyst formation. But as you can see here, there is no any impact of there is no relationship of the dysmorphisms present in oocytes at the time of vitrification, as shown here by the odds ratio, no impact on survival rate, on blastocyst formation, or the percentage of usable blastocysts, I mean the blastocysts that we transfer or we would cryopreserve. So it seems that morphology of the oocytes is not related with this outcome. But what about age? We all know that age is one of the most, if not the most, powerful confounder in assisted reproduction. So this is again data from elective freezers published in 2016. And you can see here that survival rate is more than 10 points lower when patients are older than 35 years old, which is, this is 95 versus 82. And the same thing happens with pregnancy rate and life rate per patient. And these differences are even more remarkable if we compare, of course, between the youngest and the oldest group. So age has a really key role in the success after fertility preservation. So let's bring into the table, into the analysis, different populations using vitrified oocytes. So this is a table which was originally published in Fertility and Sterility 2018, but the original doesn't contain the cancer population, but I have added just to have a whole picture of different populations using vitrified oocytes for fertility preservation. So we have donors, we have poor responders, elective freezers, and cancer patients. And of course, in the case of autologous cycles, we have a split according to age. So if we focus on older groups, results of survival and clinical pregnancy and live birth rates, cumulative live birth rates are pretty much comparable because these patients, because of the age. But if we focus on the youngest groups, if we compare donors and elective freezers, the results are really comparable for survival and for clinical outcome. So it means that young elective freezers behave like donors, which is, by the way, totally expectable. But if we compare with poor responders, then results are lower, statistically significant. And if we compare with cancer patients, young cancer patients, the results are even lower. So we can say that there is a differential outcome among two different populations using vitrified oocytes. So in the case of cancer patients, when we compared with elective freezers, as we did in our study from 2018, actually there are differences in survival and clinical outcome. But at that time, we were not able to demonstrate that this lower outcome was due to the cancer disease itself, as shown here by the odds ratios for survival and cumulative live birth rate. So we have lower outcome in cancer population, but at least with the sample size, with the number of patients we have currently, we cannot say that this is due to the cancer disease itself. What we can say in these two populations is that age is strongly related to success. And the type of stimulation, the protocol for stimulation, has nothing to do, as shown here in this slide, in this table, with survival or live birth rate. So Glenn mentioned in the first talk about that this is I think the landmark in fertility preservation. How many oocytes do I need to vitrify to increase? Let's not say we're anti-success because we cannot do this, but we can analyze this data in order to realize how many oocytes to increase the chances of success. So this is data for our elective freezers group. Again, we need to split the sample according to age. So younger than 35, older than 35. And of course, and as expected, there are statistical differences in these comparisons, but let's do this exercise here. Let's say that we have 10 oocytes vitrified for women older than young women. younger than 35. So the cumulative live birth rate is 43%, and with the same number of oocytes, this probability lowers to 25 if the patient is older. This is the data, 70% for 15 oocytes, 40% if she's older, and with 20 oocytes, that we can agree that this is a number of oocytes relatively easy to harvest in a young woman, and 2 or 3 cycles, then the probability is close to 80%, and it is 50% if the patient is older. This is the data for cancer patients, but as there are only 8 women included in this analysis, as you can see here, the curves are practically overlap, so we cannot really draw definite conclusions from this analysis. With regards to endometriosis patients, which I already mentioned that this is another condition in which the ovarian reserve is damaged, and it is more damaged over time. So these patients are really good candidates for fertility preservation. And this is a very recent study we published a couple of months ago, showing data from 1,044 women that did fertility preservation for endometriosis with a 47 return rate. So nearly 500 of these women have returned to use their oocytes. This is the mean age at vitrification. The great majority of them were diagnosed as at the severe stage of the disease, and half of them were previously operated for excision of endometrioma prior to oocyte vitrification. This is the outcome according to age, and as totally expected, again, age results are higher for the number of oocytes retrieved, embryo quality, and clinical outcome, cumulative live birth rate, 62% versus 28% between younger and older. But again, this is totally expected. And what happened with surgery? As all you know, you are a gynecologist. This is not my specialty, but you all know that when you remove the endometrioma from the ovary, accidentally you can remove healthy tissue. So let's see what happened with this after surgery. And this is the youngest group. As you can see, if they were not operated, the number of oocytes retrieved and vitrified is higher if they are still same age, younger, but they were operated. And the difference when we calculate the cumulative live birth rate is really remarkable. 73% versus 50% if they are operated versus non-operated. And if we compare it with elective freezers, results are lower in endometriosis and compared with social freezers. And this is the data for the number of oocytes needed to be vitrified, which is at the same number of oocytes is comparable between 2 populations, but when we do the comparisons between younger and older, then of course the statistical differences appear. And finally, my take-home messages, I would say that fertility preservation via oocyte vitrification can ensure fertility in these different populations, in elective freezers, cancer patients, endometriosis patients, but there are differential success outcomes among these populations. We can say that the markers of success after fertility preservation using vitrified oocytes are the number of oocytes we use, of course survival rates because it has impact on the number of oocytes we have, of course clinical outcome, and that age affects all these markers. And older people, older women, need more oocytes to equal the success rates achieved by young women. And of course, the plateau is reached by these women much earlier. And that, as I just mentioned, that there is different outcome according to different populations. Thank you very much for your attention.
Okay,
Thank you very much, Dr. Kobo, for your nice, excellent presentation. I'm sure you will receive a lot of questions. Now we reached to our last talk for this session, and it's about the breast cancer patients. Important numbers of women in reproductive age are faced with breast cancer. Although several fertility-sparing treatment options are available for these women, some specific concerns and important issues should be taken into consideration due to the nature of this type of cancer. Dr. Kutluk Oktay, who is a pioneer of this field, will share his experience on this topic with us. Dr. Oktay is a leading scientist in fertility preservation. He has contributed many key developments in fertility preservation area, such as development and performance of first successful ovarian transplantation procedures, development of different stimulation protocols in fertility preservation patients, and so on. He is also founder and first president of Fertility Preservation Special Interest Group at ASRM and co-chair of Fertility Preservation Guidelines Committee at the American Society of Clinical Oncology since 2005. Please let me allow to thank to him for his invaluable contributions in the formation of my personal career. It's a great honor and privilege for me to invite him for his talk. Dr. Oktay, stage is yours.
Thank you very much. I hope that you're seeing my slides right now, right? Is my screen shared well with you?
Yes.
Okay, great. Thank you again for inviting me for this very important conference. And just like everyone else, we are all bummed that we cannot be in beautiful Istanbul. But first of all, as customary, I'm going to acknowledge that I will be and then my research is supported by several grants from the NIH. So it actually gives me honor to be introduced by Güvenç, because Güvenç was one of my technically very first fellows, and he was very instrumental in our development of the first ovarian transplant, working days, months on animal models with me, and while I was doing the transplant, doing the laboratory aspects. He could have a great career in the United States, but Güvenç is very humble, and he values family, and she chose family and went back to Turkey, and he's doing great work there. Secondly, I also would like to thank my two other fellows who were involved in this organization, Dr. Özgür Öktem and Aylin Pelinçil, and they're both now professors, and are doing great work in fertility preservation field. So with that, I really want to dedicate my talk to my trainees and fellows. Without them, the field would not be where it is, and we couldn't have done any of the work that we have done. So my objectives are, first, just to give you the most up-to-date data on how breast cancer treatments affect ovarian reserve, update you on ovarian stimulation protocols. Glenn did a great presentation. I will, fill in few plugs that he left for me, and then come to the interesting topic of how BRCA and related gene function affects reproductive function. So this is a study that we have just got it accepted. In breast cancer, there are two common treatments. They're both based on cyclophosphamide, either cyclophosphamide-based or CMF treatments. And we divide these treatments to adjuvant and neoadjuvant. Adjuvant is the one that is done after surgery, even though that's the most common form, there's a shift in that. Nevertheless, up until now, there was no good prospective long-term data, longitudinal data, looking at the impact of these treatments. And we have completed such treatment in collaboration with Memorial Sloan Kettering Cancer Center, following these women after chemotherapy for 24 months. and comparing them to tamoxifen alone treatments. These tend to be earlier stage cancer patients, just like CMF, and determining the impact of these treatments on ovarian reserve. On the left, you're seeing the longitudinal data, and so the blue line is the AC-based treatments, and the red line is CMF-based treatments. And tamoxifen-only treatment serves as control here. As you can see, when adjusted for age-related changes, AMH levels do not change much with tamoxifen, but there is a sharp decline by 12 months in ovarian reserve. Now, one of the questions people have asked was whether the ovarian reserve could recover over time. When adjusted for age, we are not seeing any differences. So the ovarian reserve you measure at 12 months post-completion of chemotherapy pretty much reflects where this patient is, and that fits with physiology as well. On the right, I have the whisker plot of the recovery ratio. So that is the AMH post-chemo at 12, 18, and 24 months compared to their baseline. This is a whisker plot, so this barely indicates median. So you can see that tamoxifen patients are hovering around 1, but if you look at the percentage, these patients are losing more than 90% of the ovarian reserve. Again, main breast cancer chemo treatments are very detrimental. So over the past 20 plus years, we've developed numerous approaches, which we're not going to discuss again, including ovarian cryopreservation, but specifically for women with breast cancer, we have developed ovarian stimulation protocols that involve tamoxifen and letrozole. And one addition to that we have developed is a random start protocol. We developed this with one of my fellows again in Turkey, Dr. Sönmezar, and we named this random start protocol based on the fact that antral follicles are always present in the ovary and ovarian physiology. So these are now combined to make ovarian stimulation much more flexible. Again, Dr. Sönmezar is also a professor in Ankara now. He's also one of our earlier fellows. Those studies led to initially this protocol, because in the beginning we were real shy, and we said let's use tamoxifen alone. Now we evolved it into tamoxifen plus FSH, and then eventually developed this protocol by giving letrozole 5 milligrams and then adding recombinant FSH. Now, I have actually compared 2.5 to 10 milligram doses. We published that. You do not get any benefit from giving higher than 5 milligram dose. 5 milligram achieves the maximum suppression. And in the original protocol, we would add letrozole back in the luteal phase to avoid the secondary estradiol surge. That was when we were using HCG, but we have done studies to compare HCG with GNRH analog trigger, and we found equivalency. I don't have time to show those studies, and therefore this was changed, and I will show you how it's changed. But the earlier studies when we compared these three initial protocols, we had the slight edge for letrozole in terms of mature oocytes and embryos, even though these were younger patients. So future studies all focused on that. But I must tell you that in patients who are allergic to letrozole or who are already on tamoxifen, we still use these protocols and we get equally successful results. So in my mind, they are similar, but historically we have focused our attempts to letrozole, and that has become the predominant protocol. How successful is the letrozole protocol compared to standard protocols? First of all, we compared the success rates of letrozole protocol to our national data on an age-matched database, and you have actually higher implantation rates. This is no surprise because these patients do not have infertility, despite having fewer embryos transferred, similar pregnancy rate. How about the safety of this approach? We have completed several studies, but I'm showing you the latest one for a long-term follow-up of women who had letrozole protocols versus who did not, so about 400 some patients. And in follow-ups reaching up to 20 years, you're seeing here in panel A that women who had fertility preservation with that protocol, letrozole protocol, do not have different survival probability. That is also true if you have BRCA mutations or not, whether they are ER positive or negative, or whether we did these protocols, ovarian stimulation, before or after surgery. Now, as I told you, the protocol evolved from this original one. First of all, we used to start letrozole a few days before recombinant FSH to allow for letrozole to have its effect. But we found that we did not need to do that. And for patient ease, we start them together. We do use antagonists when the lead follicle reaches about 13 millimeters. Estradiol criteria is not very helpful in determining when to start antagonists because the estrogen levels are suppressed by 75%. We do leuprolide trigger. Again, we've studied and showed the efficiency. Don't have time to get into that. But one thing you have to be careful, we've shown that your stimulation criteria has to be extended by 2 to 3 millimeters. That's not because the cycle takes longer. These follicles develop antral fluid faster. Actually, the stimulation length is similar. By the way, if you just stimulated and triggered these women by on day 11 of stimulation, I think you would be right 98% of the time. So it's that predictable. Random start, it's pretty much the same protocol. Yes, we do ovulate lead follicle, and just like Glenn described, start new cycles, and you can trigger leuprolide trigger patients in the luteal phase as well. But the question is this protocol as effective as standard protocols? Originally, we've done this comparison with infertility patients, and we did show that it was. But a proper control would have been a cancer patient. So in this recent study, we compared letrozole protocol in women with breast cancer to women who had other cancers and had a regular antagonist protocol. So you have a letrozole FSH and FSH antagonist. These are both antagonist protocols. Only difference is we've used letrozole here. Despite the fact that this group was younger, you will see much higher in the letrozole group. Both total and mature oocytes, and on average, you're getting more than 2 extra embryos. In our earlier studies with letrozole, we've noticed that women with BRCA mutations, especially BRCA1, would produce fewer oocytes and would have higher risk of low response compared to untested or negative. Actually, we confirmed that in the most recent studies, in the same study that I just showed you, published in 2018, women who had BRCA mutations produced on average 5 fewer oocytes and about 3 fewer mature oocytes and about 3 fewer frozen embryos, confirming our earlier findings. We went ahead and again confirmed that these women with BRCA mutations have lower ovarian reserve in a prospective study that I'm showing you here. And this has been now confirmed by numerous studies, nearly all of them showing that that happens in BRCA1, but there's one study that shows that it happens with BRCA2 mutations. Of course, with any topic, there are party spoilers. There were a few negative studies. There are methodological issues with these studies, being retrospective, not defining control groups, not properly adjusting for variables. AMH is not normally distributed. You have to log transform it, and there's various limitations. So one of my, again, Turkish fellows, very productive fellow, Dr. Volkan Turan, and I, we reviewed this topic. And if you want to find out more about this topic, and review of all these past studies and limitations, etc., you could go to this publication. But to be able to get around all these limitations that I mentioned to you, Dr. Turan and I, we put together an individual patient data meta-analysis. This data is just being completed and getting ready to be submitted. Out of 12 studies, including ours, 5 centers gave us their raw data so that we can create one giant database. And from that, we had 824 women with BRCA positive or negative, and 4 out of 5 studies studied affected versus unaffected women. This is an important point because affected women may have more severe BRCA dysfunction, so that this way we can analyze them separately. And this is the forest plot of these studies before pooling individually. You see that 2 studies show no difference, but 1, 2, 3 studies show declining AMH levels in women with BRCA mutations. So when we did the individual patient data meta-analysis, again, it's very important to do the proper adjustment. This shows the percent reduction in mean AMH with confidence intervals. This, for example, only adjusts for center and age, about 26%. You throw in smoking and OCP use, 26% decline. Add their BMI, 23%. Leave unaffected out 25%. Pretty much, we're getting about a quarter lower AMH levels, 1/4 lower AMH levels in women with BRCA1 and 2 mutations. How about BRCA1 versus BRCA2? When we do that, BRCA1 versus negative, BRCA2 versus negative, again, we go through the cascade of adjustments. What we are seeing here is that in BRCA1, but not BRCA2, we are seeing significantly lower ovarian reserve. As a matter of fact, about a 34%, about a third lower ovarian reserve in women BRCA1 mutations, but not BRCA2. So that this data clearly shows that women with BRCA1 mutations have significantly lower ovarian reserve. And again, their centers, they combine BRCA1 with BRCA2, that dilutes the findings, etc. But this really gets around all these limitations. This data is also supported by the fact that studies shown that women with BRCA mutations have earlier menopause. There are a couple of negative studies, but one of them only looked at age at percentage of women reaching natural menopause, and only 19% of their cohort had reached natural menopause. And their subsequent study showed lower AMH in the same cohort. Another study was actually not inconclusive, and they couldn't support or refute their findings. However, I'm going to come to this. There is the selection bias. A lot of women with BRCA-related issues, they have their ovaries removed early on, and that studies do not control for that. If you look at their earliest cohort where BRCA testing was not available, so the woman could not have their ovaries removed, prophylactically, actually, you do see a difference. So I think the preponderance of evidence also suggests that they have earlier menopause. Moreover, if you look at gene polymorphism and the genes that determine age at menopause, DNA repair genes, and among them, BRCA1 comes at the top of the list. So that is a determinant of age at menopause. But do BRCA mutations have impact on fertility? There are 6 studies that looked at that. 4 did not detect any differences. Again, these are all retrospective reviews, data analysis. 1 detected lower gravity and parity. Interestingly, 1 found increased fertility. Why is this happening? First of all, again, we're talking about combining affected, meaning those who develop cancer versus not develop cancer. Again, lack of adjustment of founders. The other important thing is, as I will show you shortly, the intact BRCA allele function is impaired late in the reproductive life. So if women are having children early on, you may not see any change in fertility. And again, women who actually end up attempting pregnancy may be the ones who are selected because others have developed cancer and or had their ovaries removed. Clearly, we need more data on the impact on reproduction. But this is what I'm talking about. This is what we call the iceberg theory. What happens is that women with most severe BRCA dysfunction had their ovaries removed early on, so they don't develop cancer, or they develop early cancer. They have chemo, so you can't even test them in studies. And you have these late ovarian breast cancer cases, which we picked up in our fertility preservation studies. But the studies that look at women who have not developed breast cancer and looked at, studied those, they're looking at the most mild phenotype of this in these patients. So we actually, because BRCA1 is a key ATM-mediated DNA repair gene, and there are multiple genes in that pathway, and because women with BRCA mutations seem to have accelerated ovarian aging, and we went ahead and worked out this pathway, and it seems that ATM-mediated DNA repair and BRCA are important in ovarian oocyte aging. aging, and Dr. Titus and Fong Li were the lead fellows in this study. So what we found was that in healthy women, in their oocytes, BRCA1 and other related ATM-mediated DNA gene expression declines with age, resulting in the accumulation of severe DNA breaks. So the pink is a measurement of DNA breaks. Interestingly, same thing happens in sperm. Now, you know, title is reproduction. I don't have time to go into male, but with age, more DNA damage is accumulated in testes, and BRCA1 mutant cases and even male cases, there is increased damage to sperm and diminished reproduction. I don't have time to get into this. But in that same translational study, we used a BRCA mutant mouse model. Again, to remind you, in patients, there's higher low response in BRCA1 mutant patients and lower AMH levels. So if you take a BRCA1 mutant mouse model and a BRCA2 model, what you find is that when you stimulate them, you get fewer oocytes in the mutant mice compared to the wild type, but not in BRCA2. And they have fewer primordial follicles, and they have more DNA damage in their ovaries. This actually is similar to what we found in human ovaries. We were able to study ovaries from women with BRCA mutations, again, with a fellow, Dr. Lin, at that time at Harvard, and compared primordial follicle density to controls. So you see that women with BRCA mutations, they start lower, and they actually lose their reserve faster, especially after age 35. Their ovaries also accumulate more DNA damage than the control ovaries. So there is an overall accelerated aging process in the ovaries of women with BRCA mutations. So this is the model. In parallel studies, we've also shown that the key mechanism of chemotherapy-induced oocyte death is double-strand DNA breaks. And we have a nice paper in Molecular Human Reproduction just this year. I would recommend you to read that. Chemotherapy induces double-strand DNA breaks, and that induces apoptosis. Some oocytes may be able to repair them and survive. So what happens in women with BRCA mutations, they still have an intact allele. That allele's function declines with age. As it declines, you have more DNA damage, both in oocytes and everywhere else. So they're more sensitive to environmental genotoxicants or possibly chemotherapy. They accumulate the DNA double-strand breaks and have mutations. This results in chemotherapy as well as accelerated oocyte death and earlier menopause. So putting these together, we said, is it possible that women with BRCA mutations can lose more eggs after chemotherapy because they are DNA double-strand break repair deficient? So again, with the Memorial Sloan Kettering, we have followed women with breast cancer longitudinally for up to 24 months and compared the AMH recovery rates between the positive patients and negative and low risk not tested. We also had a mouse model where we knocked the BRCA gene, exposed the oocytes to chemo, and see if they became more sensitive to chemotherapy. So this is what you're seeing here. This is percent recovery of AMH levels before chemo to up to 24 months post-chemo, 12 to 24 months post-chemo. If you're not tested and negative, your recovery is up here. But if you're positive, your recovery is down here. This is about 4 to 5-fold difference. This is for all chemo. If we focus this to one type of most common chemo, again, clean data, showing much less recovery in patients with chemo. We biologically confirm this. We knock down the BRCA gene in oocytes, and these are controls, and then expose them to chemotherapy, the A agent, adriamycin or doxorubicin. And they have much higher death, confirming this. So here's a double whammy. Women with BRCA mutations may start life potentially lower number of oocytes. They may lose them faster, and they may lose them even faster if they have chemotherapy. Now, BRCA mutations is again, they are the tip of the iceberg. There are more and more mutations that are being identified in the same pathway that are associated with breast cancer. One of them is ATM. This is one of the most common mutations in the general population, and actually in both patients and in animal models causes infertility and ovarian failure. So now we're focusing our efforts on looking at various other mutations in breast cancer population, and the overall impact might be much larger. So in conclusion, breast cancer chemotherapy significantly diminishes ovarian reserve, and more severely in women with BRCA mutations. There's strong evidence that BRCA mutations, especially BRCA1, affect ovarian reserve and ovarian aging. Fertility impact is questionable at this time, but there may be more impact in later reproductive life when the intact BRCA allele function goes down, but more studies are needed. The difficulty is that most severely affected women, and will come to men in the future, are eliminated from studies because of chemotherapy and early removal of gonads. But all these findings gave us a window into the role of DNA repair in reproductive aging, and there's a lot is coming down on that path. And we are, as I said, currently studying all other mutations now in the same pathway, which may give us more information on DNA repair and reproductive function, as well as reproductive function in women with breast cancer. With that, I want to acknowledge my laboratory at Yale, my current fellow, Kasha, Shu, all current past fellows, collaborators at Yeshiva and Memorial Sloan Kettering, my institute members, and all current past fellows. Thank you very much.
Dr. Oktay, thank you for your nice and comprehensive presentation.
Thank you very much.
Thank you very much. So now we quickly move to Q&A session. Due to the time constraints, we can only have a few questions for each speaker. And so I'm going to take the advantage of asking the first one to Dr. Anna Kabo, because it's related to my the field of experience. The question is about oocyte cryopreservation. What is the age limit for oocyte cryopreservation for both elective and cancer patients in your practice? So based on your extensive data, do you have an age limit from the female side?
No, actually we don't have a limit, because as I just shown, we can have success rates, I mean the baby life rates in patients older as 41, 42. So what we need to do is to know exactly, at least in our practices, in our hands, our success rates, just to explain them clearly, their possibilities, just to avoid expectations, false expectations. But we don't have a limit of age. We try to make them to come earlier, but that's the thing.
Any question for Dr. Chapman?
Yeah, I have a question for Dr. Chapman. Dr. Chapman, I wonder if you see any differences in embryos, the embryo development, which generated from follicular phase or luteal phase in terms of embryo development, blastocyst rate, or chromosomal abnormalities?
Thank you for that question. No, we haven't seen any difference. So follicular phase oocytes, luteal phase oocytes result in the same number of blasts, or same percentage of blasts, I should say, compared to our typical early follicular day 2 starts. If we compare them to the control population of infertility patients. So egg quality appears to be the same. You're obviously going to use those embryos in a subsequent cycle if you start in the luteal phase or late follicular phase. So you've taken out the endometrial aspect of the simulation from that. But no difference at all. We only see a difference if you have frozen eggs and then you thaw those eggs and fertilize. In future, you'll have a lower blastulation rate from frozen eggs, and that's the only thing that we have seen.
Thank you very much.
So we have many questions indeed, but unfortunately, as I mentioned, due to time constraints, we cannot answer all of them. But I would like to be sure that all the questions will be diverted to the speakers after the session, so all of them will be answered. And
Should we ask about COVID?
Yeah, but there's one question for Dr. Kutlu Koktay as well. So what do you think about the pharmacological approaches to diminish the extent of ovarian damage and premature follicle activation?
Yeah, so the question is there a non-surgical approach to preserve fertility? And there's not a short answer for that, but based on a very careful evaluation of clinical studies looking at weaknesses and strengths and all the basic science data, I do not believe that ovarian suppression will protect primordial follicle reserve. However, there are other attempts at finding a solution there. One of them is sphingosine 1-phosphate. It's a ceramide-induced death inhibitor that has been shown in human ovarian xenografts that it blocks chemotherapy-induced damage. I must admit that we have completed studies using single-cell RNA sequencing in human ovarian tissue, and we do not find significant evidence for follicle activation as in response to chemotherapy. So any treatment that blocks chemo-induced oocyte, that has to be blocking DNA damage. So we're focusing our pharmacological efforts in finding agents that can block DNA damage or enhance DNA repair in ovaries.
Okay, do you think that in the future the CRISPR technology might be used for fertility preservation to correct the gene mutation about BRCA?
Thank you for that question. CRISPR, and there's also what's called a DCAS9 CRISPR, which enables you to, without permanently changing gene function, but manipulate gene function. And as a matter of fact, this is one area that we're working on. BRCA function declines with age, and this might be due to epigenomic changes, and not only in women with mutations, but women who lose BRCA function with age. There may be ways to, through CRISPR or DCAS9 CRISPR, to manipulate that. Currently, the concerns are off-target effects that you're trying to address the mutation or epigenetic change through CRISPR, but sometimes your guide RNA may end up in different targets, and that is a controllable eventually issue. And pilot studies have already shown that you can correct in animal models key diseases by CRISPR. So that has a future, obviously, for a lot of these women. They have some option of selecting embryos that do not carry the mutation to block passing this on, obviously, by PGT-M.
Okay, so we're running out of time, but I should ask one question to each speaker before the session ends. There are many questions regarding the COVID-19 pandemic. So people wonder how each speaker is actually handling this pandemic in your clinical and laboratory practices. Can you just give us 3 main recommendations from your side? We can start with Dr. Shatman.
Sure. We have, obviously, we closed our center down for about 8 weeks when the pandemic was at its peak. So I think really starting up a practice or starting to treat patients requires the infection rate to be quite low. Number of positive tests, number of new cases needs to be on the decline or quite low before you actually start providing services again. We also have done a few things. One is social distancing in the clinic. We test patients at the start of stimulation, and we also test patients at within 5 days, or really 3 days before egg retrieval. So in all of the situations, we've only found 5 patients that have tested positive, 3 at the beginning of stimulation, 2 that were negative at the beginning of stimulation, but became positive on the day of, or the day of the trigger, or the day before the trigger, and all those 5 patients were canceled and sent to their internist. So I think, by adequate screening, doing it when it's safe to do so, and testing patients before you start stimulation is one of the best ways we can try and keep our patients safe during their fertility journey.
In our case, we are following very strict protocols that are developed from the Spanish Society for Spanish Fertility Society, and we also developed our own protocols. And it depends on the incidence of contagious in our geographic area. So, for example, now that the infection is increasing in our clinic in Valencia, for example, let's say, so we need to do PCR to every patient coming to the ovarian retrieval. And if, of course, if the PCR is positive, then we don't initiate the stimulation. And there are also other measures like in this, let's say, in this acute stage of the contagious in our area, we need to measure the temperature once they enter the clinic. We also have safe distance in the waiting rooms, and those windows to protect from the clinician and the patient. Only one patient, one person with accompanying the patient, and there is a very complete and very strict protocol that we are following.
Do you use the closed carrier system in the lab?
Sorry?
Use the closed carrier system in the lab, like vapor phase, cryopreservation, something like that?
Vapor phase.
For oocyte cryopreservation, do you have special precautions like vitrifying everything in a vapor phase, storing in a vapor phase, and the closed carrier systems?
We do store in vapor phase since the beginning. We don't use liquid nitrogen just for logistics. Because these tanks have a huge capacity, but not special measures in the specific vitrification protocol.
Okay.
Not really, because these patients are PCR negative. They tested negative once they oocytes or embryos come to our lab.
Okay. And Dr. Oktay?
I'm going to echo what Glenn said in terms of testing patients, but obviously one obvious thing is that we do, whenever we can, all consultations through Zoom, and to minimize unnecessary contact with patients. There are a couple of interesting, innovative things some clinics try to do. One is that, I don't know if you've heard about Butterfly IQ, but an ultrasound probe can attach to your iPhone. One clinic actually trained their patients to do their own ultrasounds and send the pictures and share it with them. And so there are clinics out there. They're trying to push this to the most remote fashion. But I would say that I would agree with other speakers.
Okay, and we would like to thank all three speakers for the nice contributions.
Thank you.
And again, so we will have a short break, and then the next section is going to start in 15 minutes. Thank you very much.
Thank you. Thank you for having us.
Thank you very much.
Hold on, before.
starting the last session of the meeting. Before we start, I would like to thank to everyone, to audience, to the speakers, scientific committee, and pharmaceutical companies for their support and our assistance. Now, the last session is on the future aspects of fertility preservation options. Ovarian tissue cryopreservation and transplantation is one of the important fertility preservation treatment options. This treatment modality has become an established treatment option with the recent development and accomplishments. However, several concerns and issues like follicle survival rates and reseeding of malignant cells, etc., are still needed to be solved. Many works and improvements have been made on this subject. Artificial gonads are one of the promising improvements in this area.
Yes, in this session, we have two worldwide well-known speakers to discuss the future of fertility preservation from artificial gonads perspective. Let me introduce our first speakers, Dr. Marie-Madeleine Dolmans. She is the head of the Gynecology Research Laboratory at the Université Catholique de Leuven in Brussels since 2012 and chef de clinique associé at the Clinique Universitaire Saint-Luc, Brussels, Belgium. She has been a frequent speaker in many international fertility congresses, and she is now Vice President of the International Society for Fertility Preservation. Dr. Dolmans serves on the editorial board of Fertility and Sterility and the Journal of Assisted Reproduction, and is a reviewer for numerous other international scientific journals. Her extensive publication work covers fertility aspects of ovarian tissue cryopreservation, fibroids, and endometriosis. Dr. Dolmans, one more time, we would like to thank you for being with us today. And now the stage is yours.
Mr. Chairman, thank you for this nice introduction. Ladies and gentlemen, Mr. Chairman, I will present you today artificial gonads, and I will take the part of the ovary. So let's go to the next slide. Yes, I have nothing to declare, and we will first see together why should we need this artificial ovary. Well, let me start with a slide that I showed yesterday with the indications of ovarian tissue cryopreservation. You see that I have put some circles. 22%, leukemia, 11%, non-Hodgkin lymphoma, 6%, borderline ovarian tumors, 14%, sarcoma, 10%. So all these diseases are frequent in terms of ovarian tissue preservation, but for all of them, we had some doubts about the risk of transplanting the fragments. So what we have done was first with leukemia, as it is a blood-borne cancer, we wanted to see if it was safe. And indeed, these studies could show that there was a risk of ovarian involvement in acute leukemia. And so the study was done with mice and also with molecular biology. We could state by PCR that 70% of the fragments that we tested for coming from patients with acute leukemia were positive for the marker of leukemia. And in fragments, so we put, as you can see in the picture, the fragments for 6 months in SCID mice. Well, half of the mice could develop, as you can see here, leukemic mass. So for that one, it was not really reassuring. But for non-Hodgkin lymphoma, we could also find some patients, a few, in which there was an involvement of the medulla, as you can see here, by the non-Hodgkin lymphoma, so CD20, which is positive in this case in the ovarian tissue. From patients with borderline ovarian tumors and also from patients with advanced stage breast cancer. And this allowed us to come to the conclusion that was published in these two reviews and that I will show you briefly now. Starting with the Fertility Sterility paper 2013, we could conclude that leukemia, neuroblastoma, Burkitt lymphoma were not safe for fragments transplantation. Also, we could split the breast cancers into different stages. In the very low risk category, we have the breast cancer stage 1 and 2, and in the moderate risk, stage 4. Also was put in the moderate risk the non-Hodgkin lymphoma, as you have seen an example, and the Ewing sarcoma, which was not the same for the other sarcomas that we could put in the low risk category. So it is quite safe to transplant back ovarian tissue from patients with this type of sarcoma, and the borderline ovarian tumors were put in the moderate risk. To conclude that part of the study, we can say that it is important to test the ovarian tissue before ovarian tissue transplantation. And as quality control analysis, we can propose histology, specific markers by immunohistochemistry, very specific markers by molecular biology that we can do by PCR or NGS, so gene sequencing. And also, we should not forget to test by xenografting with the long-term grafting to immunodeficient mice. Of course, it takes a while before the patient is reassured, but then if it's positive, we know we have done good by testing, and if not, well, we can go ahead. But we have seen these leukemic patients, and if we do all this testing and it is positive, what can we propose to these patients? Well, I think we can say there are not candidates for ovarian tissue transplantation. As category of patient, we could confirm a risk, but still there are candidates for ovarian tissue cryopreservation. In fact, many of them have their tissue frozen that we can test. So what can we do with that frozen tissue? There should be a method to avoid transmission of malignant cells. And first, in vitro culture is tested in Evelyn Telfer's laboratory and is one of the two options to go. The other option that I will present you today is the artificial ovary. So let's see together, how shall we prepare and what can we do to have that artificial ovary? So thinking, we need three components. Of course, the major component that we should start with is isolated follicles. And then we might want to add some ovarian cells around these follicles. And finally, to stick all these cells together, we will need a matrix. So starting with the isolated follicles. First step is to form this tissue that you see here in fragments, isolated follicles. Indeed, in human tissue, well, ovarian cortex is very tough and hard, and it's really not easy, like in mouse, to test isolated follicles. So the way to issue is to go with enzymatic digestion. Isolating these follicles, one with liberase, the other one with collagenase, to isolate enzymatically human ovarian follicles. So this was the first proof that it was feasible. Then we need to see further if these isolation procedures are not harmful for the follicle integrity. And another PhD student in our lab, Julie Van Acker, she could prove by electron microscopy, together with Professor Camboni, that it remain intact after this isolation procedure. So we could go ahead because it's feasible, the follicles are intact. What was the next step? Well, first, we could see that after isolation, well, sometimes we had extruded oocyte from the follicles. That was too much. Or other we could enough. So with improving these isolation methods, and Dr. Shetty, she could develop a modified and tailored human follicle isolation procedure. Indeed, what she has proposed is to stop isolation procedure at different steps. So you see, each time we will recover some intact, fully isolated follicles. And that was also a way to have more follicles isolated with that new method. So I think we can say now that the method to isolate human follicles is optimized. And this is to the mesocardial aspect. Okay, that is done. But what about these follicles once they are isolated? Are they still able to grow? The proof of concept was done by cells, putting them into a kind of matrix, which was in fact coming from the patient's blood. It was a plasma clot. And that plasma clot with these human isolated was transferred into the skid mice, just next to the mouse ovary that you can see here at the right by histology. You see the mouse ovary, and you see here the results of 5 months grafting of human isolated follicles. And we could prove that the antral follicle there after 5 months was really coming from a human patient. I will show you the next slide here. You see this is a specific anti-human antibody, Ki67, showing proliferation of these human granulosa cells after 5 months grafting. So, okay, these follicles were still functional after this long-term grafting. But in fact, the aim of preparing all the artificial ovary is that we want to offer that technique to leukemic patients. So what about possible leukemic contamination with that isolated follicle suspension? So Dr. Soares, she evaluated E3 follicle suspension to graft safely that suspension back to cancer patients. And so the idea was to see with leukemic cells that you can see here in green. These are BV173 cells. These are typically leukemic cells. And we want to see if these leukemic cells are still present after follicle isolation. And in fact, you see that after follicle isolation, normally with a normal technique that we pick up under the microscope, well, you see all these little dots. Some points there, some dots are stromal cells, but 1, 2, 3, 4, 5 points are leukemic cells because you see they are green. So the idea was to purge this follicle suspension. And in fact, after a first, a second, and a third wash, you can see here that she could recuperate and wash these leukemic cells in order to progressively eliminate contaminating leukemic cells from the follicle suspension. So this allows her, after the right, to end up with a follicle suspension completely safe of these leukemic cells. And so testing that on tissue from leukemic patients, she could state that it is possible to eliminate malignant cells from preserved ovarian tissue. We want to isolate these follicles. So to conclude that part, the code for human follicle isolation can be applied in a clinical setting, can be personalized according to the ovarian tissue properties of each patient, and is safe regarding the reintroduction of malignant cells. Second, we need some ovarian cells to be put in that matrix. So why? Because we thought that ovarian cells are a biological support for the transplantable artificial ovary. First, stromal cells are essential for follicle development. Indeed, it is the stromal cells that are differentiating into theca cells. And another kind of cells, the endothelial cells, because they can improve the vascularization of the grafts. And that we could show some time ago. Endothelial cells, we have better grafts. So for the ovarian cells, the best biological support would be these stroma cells. And the proof of that was that the freshly, so coming from fresh ovarian biopsies, freshly isolated ovarian cells from the medulla showed to prove higher vascularization in the graft. In that slide, you can see human and murine vessels. So this is a CD34 immunothelium, and you have the murine vessels. And so if we co-transplant in the artificial ovary some ovarian cells coming from the medulla of the patient where there is rich vascularization, we enhance the quality of the artificial ovary. Ending with the matrix. That's an important point. We have different matrices that we tested in alginate. It's Professor Amorim working on that, and she aims to have a scaffold that maintains the original 3D structure of the follicles, but it should also allow the follicular growth and development, because you know we start from a 35 micrometer follicle, but just before ovulation that same follicle can have 2 centimeters. So the matrix should enable this follicle to grow. It has to be easy to handle because we need to give it to the surgeon to transplant, and of course it needs to be biocompatible. So for alginate, I showed you here 2 articles, but finally, after all these years of testing in the lab, we end up by stating fibrin might be the best. We tested first in an autografting model with mouse, and you see here the artificial ovary with fibrin after 1 week of grafting in mouse, and we can see that already we have developing follicles in that matrix. And here you see the result published in RBM with human isolated follicles in fibrin, and she could state that a follicle recovery of 22% was obtained. It can appear to be very low to you, but if we compare to the follicle survival rate in human tissue, as Professor Klaus Andersen presented yesterday, the results obtained by several, well, it was 30-35% of survival. So finally, we're not that far away. And here you see the latest results with fibrin that were published, and we could conclude that fibrinogen 50, thrombin 50, these are the concentrations of the different components of fibrin, well, resembles more the human ovarian cord. After all these studies, I can summarize the idea of the transplantable artificial ovary in that slide. So we know that we have a patient before cancer with a risk of ovarian tissue involvement, but still candidate tissue. Indeed, we don't have any other solution for a young leukemic patient. So we have that tissue frozen there. The idea is when when she wants to become pregnant, when she feels she needs to use her frozen tissue, we can thaw the tissue, isolate the follicles from it, and put them into a transplantable artificial ovary, together with some ovarian cells that can be isolated from her native contralateral ovary. After putting all that together in the matrix, we hope that the surgeon will be able to graft that artificial ovary, and we really hope that these patients also will be a category that will have hope to have kids one day with the new techniques that the modern world is able to present. So of course, all these studies are done thanks to a big team in the research lab. I want to thank all my colleagues in research, thanks the funding, thanks you for your attention, and I really hope to see you live in person, I mean, in Brussels for the ISFP Congress in November 2021. Thank you.
Thank you, Professor Dolmans, for this nice and comprehensive presentation. Now we move to the second speaker, and we continue speaking in the near future about artificial gonads. Our second speaker is Dr. Yoni Bayert. He obtained his PhD in medical sciences at the Free University of Brussels with a thesis on male fertility preservation and published several papers in reproduction and tissue engineering journals. Since 2016, he has been working as a postdoc fellow for a scientific research foundation, Flanders, with a focus on exploring advanced 3D culture systems to model the testis. He was a visiting scientist at the Karolinska Institute and Monash University and held the position of president of the Network for Young Researchers in Andrology until 2019. It's my great pleasure to welcome Dr. Bayert to the stage.
Good evening, everyone. And thank you, Mr. Chairman, for this nice introduction. And I would also like to thank the organizers of this meeting for giving me the opportunity to talk about the artificial testes and their potential future in clinical practice. So first of all, I would like to let's try to go to the next slide. Yeah, first of all, I would like to share with you that I have no conflict of interest. And then to continue my presentation, I would like to draw your attention to this graph on the left, showing that thanks to advanced cancer therapies, the overall 5-year survival rate of childhood cancers has increased up until 85%, and it's still improving. Unfortunately, cancer therapies also have long-term side effects, such as gonadotoxicity through the depletion of spermatogonial stem cells. As a consequence, 66% of the childhood cancer survivors have abnormal sperm parameters, and 80% of those who received aggressive chemotherapy are infertile for life. Now, knowing that 1 in 640 young adults are cancer survivors, and that infertility adversely affects the quality of life, it is important to have a good fertility management program. So when dealing with adults, the first reflex is to bank a sperm sample. However, this is obviously not possible when dealing with prepubertal patients due to the absence of spermatogenesis. For them, we can cryopreserve testicular tissue biopsy, because these biopsies already contain spermatogonial stem cells. Now, for an overview on tissue cryopreservation and sperm cryopreservation, I refer to the excellent presentation of my mentor, Professor Herman Tournet. Yes, then later on, these frozen samples, they can be autologously grafted to the patient, or they can be dissociated to isolate and propagate the spermatogonial stem cells before an infusion in the tubules of the patient in order to restore the fertility. Alternatively, when there is a risk of cancer cell contamination, it is important to generate the gametes in vitro through in vitro spermatogenesis and use them in assisted reproductive technologies to generate healthy offspring. So for the rest of the presentation, I would like to go deeper into my main research interest, which is in vitro spermatogenesis. So as you all know, the testis is has both exocrine or sperm producing and endocrine or testosterone secreting functions. And so the quest to replicate these processes using lab-grown testicular tissues or artificial testes has been going on for already a century. So the first studies in the 20s and the 30s, they used rabbit and neonatal mouse testicular fragments cultured on plasma clot, and they were able to show initiation of meiosis from the spermatogonial phase, and this for the first time ever. And this was a very important event and led to a whole list of attempts to perform in vitro spermatogenesis, but actually the major hurdle for these studies was always to pass meiosis. Until 2011, until the group of Sato et al. Published their groundbreaking paper on in which they showed for the first time ever complete in vitro spermatogenesis. And the setup was actually quite simple. So the success formula included keeping the tissue fragments intact, culture them at the gas-liquid interface, and supplement the medium with knockout serum replacement. And this serum replacement was found to be the key, very crucial to induce the spermatogenesis, so that after 6 weeks, mature spermatozoa could be isolated and used to generate offspring. And this offspring was found to be healthy at the genetic and the epigenetic level. So this study has really, gave a boost to the field and inspired many researchers to extrapolate the findings to other species, including human. And the most advanced study may be the study by De Micheli et al. In 2018, in which they showed the cultivation of prepubertal tissue fragments and reported a long-term stable release of testosterone in vitro, but also they observed meiotic marker expression, but also post-meiotic marker expression, and even the formation of haploid cells using the in situ hybridization technique. So yeah, even though it was inefficient and safety still has to be addressed, these results are very promising and actually support the further implementation in the clinic. Now, while organotypic, the organotypic culture system has specific advantages, so it preserves the testicular architecture and it is also very user-friendly. And it is therefore actually the ideal system to achieve the straightforward goal in fertility preservation, which is maturation of primary spermatogonial stem cells. However, at the same time, it also lacks a specific characteristic, namely customization. And customization, I mean with this, that it gives you the opportunity to decide which cells, primary, cultured, naive, or manipulated, you include in your system and how they grow in your system. So this is a feature which is actually offered by a new technology. It's called the testicular organoids, and these are artificial testes, as you can call them, formed by or formed from single cell suspension, possibly supported with 3D substrates or other ECM equivalents. So this technology has gained a lot of attention in the last years, and I will give you now a brief summary on the latest developments. So we were actually the first to develop a protocol to form testicular organoids, and for this we first isolated adult testicular cells and then seeded these cells on a scaffold consisting of decellularized human testicular matrix. So the idea was to actually give the cells in vitro the exact same ECM microenvironment they have in vivo, and then the scaffold in turn would guide the relocalization and the reorganization of the testicular cells in vitro. The culture medium we used for this study is, and actually most of the organoid studies, is based on the culture medium of the successful organotypic culture system. And so we detected a stable testosterone release during the 4-week culture period, and that the testicular organoids were able to maintain the most important cell types of the spermatogonial stem cell niche, even proliferating spermatogonia, although the cells were not in their native configuration. And what we know from the organotypic culture system is that it is crucial to have this specific 3D configuration of the testicular cells. So the results were not as expected, and the question arose, is this due to the cell age or due to an inadequate scaffold? So the next two studies I will discuss, they try to find an answer on this question. So in this 2017 biomaterials paper, the authors encapsulated juvenile, so immature red testicular cells in not a solid scaffold as we did, but in an hydrogel of mitrogel. So the encapsulated cells in the matrigel were placed in this green region, as you can see here, and then covered by 2 other layers of matrigel to create actually a 3D layer gradient. So this resulted in nice red testicular organoids containing these small spherical structures with Sertoli cells separated by these green myoid cells, and also harboring chains of spermatogonial stem cells. So they were really able to replicate the spermatogonial stem cell niche in vitro, and their model allowed to study known in vivo regulators of the germ cell to somatic cell associations. For instance, they showed that supplementation of the medium with retinoic acid induced increase in the germ cell percentage, and supplementation with interleukin-1 alpha and TNF alpha impaired the Sertoli cell to Sertoli cell connections through the inhibition of the blood testis barrier formation, and these observations were already done in vivo before. So there was another study by Vermeulen et al., and they also used decellularized matrix hydrogel, but falling back on providing the natural ECM environment, so the testicular matrix actually, to encapsulate prepubertal pig testicular cells. So they reported a stable testosterone secretion in this, as you can see, with these light gray bars, but it was significantly lower compared to the control, the organotypic culture system, represented by the black bars in this case. Nevertheless, their organoids contain tubular structures with germ cells, Sertoli cells, Leydig cells, and pertubular myoid cells. They even reported the formation of post-meiotic germ cells, although it has to be said this was a very rare event. So from the decellularized matrix studies, it is clear that the age has an enormous impact on testicular organoid formation. The role of the composition of the matrix is not so clear. So there was an American study that tried to shed a better light on this question by directly comparing 2D versus 3D, ECM versus ECM-free, and immature cell versus mature cell cultures. And they concluded that these mouse testicular organoids were best made in 3D ECM-free, so extracellular matrix-free environments, and that that actually immature mouse cells have the property or the possibility to self-assemble into testicular organoids containing tubule-like structures, also maintaining germ cells, although in vitro spermatogenesis was again not reported. But an important finding is that this self-assembly is an innate property of the immature cells, as you can see here, because the adult cells in their study completely lacked the morphogenic capacity. Interestingly, the formation or the testicular organoid formation ability of adult cells could be rescued by adding at least 25% immature cells in the chimeric organoids. So the take-home message here is that so the formation of testicular organoids is really relying on the age of the donor cells. But there may be ways to circumvent the morphogenic capacity of your cells by letting the researcher decide where you deposit or where the cells are deposited. In our 2019 proof of concept study, we actually 3D bioprinted juvenile interstitial cells into a mesh-shaped scaffold, and use this the macropores of this scaffold to be filled up with tubular cells isolated from an acrosin 3 EGFP reporter strain. This reporter strain has green post-meiotic cells in the testis. So what we found after 6 weeks is that we were able to create artificial testis with two compartments, interstitial and tubular compartment. In the tubular compartment, we found round spermatid and elongated spermatids. Even though the efficiency was way lower compared to the organotypic control condition, this shows that it may be possible to create an artificial testis from adult cells using 3D bioprinting. So also other research groups, they were exploring the possibilities of testicular organoid technology and also the limitations of this technology. Specifically, this study by Sakib et al. In 2019, they showed that they actually adapted the technology to microwell cultures, and this is ideal to form testicular organoids from using prepubertal cells from different species, including the human, in a high throughput fashion. And actually, they showed that it was possible with using as few as 125 cells per scaffold. So even though, 125 cells per organoid. So even though these organoids had an inside-out configuration, it shows the potential of this system to use it for the rapid toxicity screening. So also situated in the toxicology area, we recently performed multi-organ chip cultures, including both a tissue equivalent for the testis and for the liver, connected by a microfluidic stream, and this actually emulates the physiological context of organs in the human body, and this allows to not only study the effects of administered chemicals directly, but also indirectly by because the formation of metabolites is enabled by, in this case, the addition of liver spheroids. So we decided to challenge our system by adding the cytostatic agent cyclophosphamide. This agent shows toxicity and germ cell depletion only after a bioactivation by the hepatocytes towards phosphoramide mustard. So by spiking our medium during 1 week, we were able to detect an elevation of the expression of 2 CYP enzymes involved in the metabolization pathway of cyclophosphamide, and also a drastic decline in the number of germ cells in the testicular organoids cultured in the presence of cyclophosphamide. So this really shows that we were able to functionally link those 2 models on a chip. So I hope that I was able to show you the plasticity of this new technology, and that we are able to easily perform functional assays on testicular organoids, and this can lead to new insights in testis development and spermatogenesis, but also the possibility to form organoids from different cell sources opens new therapeutic avenues for Sertoli cell only patients, and also raises hope for carriers of a genetic disease or of a disease gene to father healthy children. And then the combination of miniaturized testicular organoids and microfluidics really facilitates the screening of substances for unwanted or wanted effects on spermatogenesis. And then lastly, the 3D printing of living tissues may one day enable the transplantation of the replacement of missing testicles, and not by these implants, but by a living organ. So to conclude, organotypic culture system is already in an advanced stage, although the efficiency has to be improved and the safety has to be assessed before clinical application is possible. It is a very accessible technology. It excludes cell manipulation, and is therefore an ideal system in fertility restoration with the straightforward goal of SSC maturation. On the other hand, testicular organoids from cell suspensions is a new technology. It's in an early stage at the moment, and further research has to focus on improving the support of germ cells in long-term cultures. But the big advantage is that it is a tailorable model and combinable with advanced technologies, and is thereby recommended for specified stem cell therapies and certain research and development applications. So this is the end of my presentation. I would like to thank you for listening, and certainly also my colleagues, collaborators, and funding agencies. So thank you very much.
Thank you very much, Dr. Baratz, for your great presentation. We have moving quickly to the questions. We have a question from the audience. First question to Dr. Dolmans. The question is, what do you think about the reproductive outcomes in artificial ovary? What will be the difference comparing IVG?
Sorry, I could not hear the question.
Okay, repeating. What do you think about the reproductive outcomes in artificial ovary? What will be the difference comparing IVG?
The difference with in vitro growth. Well, it's a difficult question because we are not that far in research to be as close as a application is not that good. There is a need of more than 100 one antral follicle, which is not 100, I do agree, but still it's better than 1%. This is only a survival rate, so it's not a developmental rate. Of course, I think it will be lower than the ovarian tissue fragments transplantation, but the reason why we took the option of the artificial ovary compared to in vitro culture is that to mimic that, like you with all the cytokines and or whatever that can arrive to the graft might be better and easier because we need to. That's it.
Thank you very much for your answer. And the second question goes to both speakers. And before moving to artificial gonads, do you think that the use of autologous adult stem cells find their way in the clinical practice? Dr. Dolman first.
To the artificial ovary or gonads?
Do you want me to repeat the question?
Yes, please. Yes, please.
Yeah. Before moving to artificial gonads, do you think that the use of autologous adult stem cells find their way in the clinical practice?
Okay, before, I am not sure at all, because it's a huge topic, a big field in research. Major progresses have been done and are made so far, but still having to a clinical application, it's another point. And so we know that from research to clinic, it takes years. It's not a question of months or weeks. So I am not sure that the adult stem cells will another opinion on that? Yoni?
Yeah.
We have problem with the connection.
Yes, but I think I can continue answering the question. So
Okay.
it really depends on what is meant with autologous stem cells. So if you talk about adult stem cells being the spermatogonial stem cells, yeah, definitely there is a place for spermatogonial stem cell therapy in the clinic. At the moment, fertility restoration using spermatogonial stem cells is in the preclinical phase. What is in the clinical phase is already the banking of the testicular tissue pieces. So now many research groups are actually translating the findings from the animal models to the clinic, but we have to be sure that it is safe on the genetic, epigenetic level, but also that we do not reintroduce cancer cells. So that's why I think the first step would be the grafting of tissue pieces in case of non-malignant treatments of the cancer patient. So I think that this is in the first line. And if there is a risk of cancer cell reintroduction, then we can really focus on in vitro spermatogenesis.
Okay, thank you very much for your answers. Obviously, this is the end of the symposia. Before we turn off the lights, I would like Necati makes the last.
Yeah. Okay, so dear friends and colleagues, I think we have now reached the end of the scientific program, and we are extremely happy to see that the meeting has fulfilled all of its promises. And we would like to thank you so much for all of your positive and flattering messages, which has already driven us, the organizing committee, to plan the several upcoming events even now. But there are many people that we should be extremely thankful. The first, our speakers. For 3 days, they spared their valuable time in front of their computers for hours to make this broadcasting live, and be sure that this meeting is not a pre-recorded event. So all of these sessions were actually broadcasted live. So we are extremely thankful for the speakers. Secondly, I would like to thank especially to Mrs. Banu, her team, and all the members of Pickup Technologies. Without their relentless effort and continuous energy, such organization could not be possible. And a big thank you and goes for you. Third, we would like to show a sincere appreciation and applause to our sponsors. Such support was so important for us, especially these difficult times that we had been through. Fourth, we would like to thank all of our participants. Without your support, interest, criticism, messages, we feel that we should do better, and be sure that we will. I hope that all of you had enjoyed the presentations, get benefits from the contents. On behalf of the Managing Board of Turkish Society of Fertility Preservation, we hope to see you in another society's activities. Thank you for your contributions.
Thank you.